Okay, here we go. Welcome, everyone. Welcome to the Catholic Studies Lecture Series. My name is Dr. Kevin Vaughn, Director of the Bregelman Program in Catholic Studies at the College of St. Scholastica, a proud sponsor of this series. The Bregelman Catholic Studies program is endowed by the Bregelman Sisters of St. Scholastica Monastery and named for Sister Athanasius Bregelman, president of the college from 1942 to 1954, and Sister Bernice Bregelman, who taught scripture and other classes at the college from 1941 to 1972. The program showcases Catholicism as a monument of human flourishing and is designed for students interested in deepening their knowledge of Catholicism's rich tradition and its interaction with culture. The lecture series furthers the program's mission by inviting informed and engaging speakers to address topics relevant to the church, academy, and society. Well, it's difficult to think of a more relevant and important topic than the one that we are going to discuss this evening. This last decade has seen the rise in a number of states that have legalized physician-assisted dying, and there are active efforts to advance it in additional states, such as this one, Minnesota. But more than a political issue, end-of-life care has touched all of us who've had to navigate serious illness and old age in either ourselves or our loved ones. And so tonight we are blessed to have Dr. Natalie King here this evening with us to help us navigate some of these waters and to offer some guidance from a Catholic perspective. So a little bit about Dr. King. Dr. Natalie King is a palliative medicine physician who specializes in caring for patients with serious illness and nearing the end of life. She is originally from Indiana and attended the University of Notre Dame. While in medical school at Tulane University, she founded the Catholic Medical Association student section. She completed internal medicine residency at the University of Utah and palliative medicine fellowship at the Mayo Clinic in Arizona. After fellowship, she worked for several years as a palliative medicine physician in Colorado, helping lead her hospital's ethics committee and teach trainees. She completed a master's degree in bioethics from the Ohio State University, partnering with the United States Conference of Catholic Bishops to improve education around palliative care for Catholic laity. She has organized a forum for the Catholic Medical Association on end-of-life issues, and she is passionate about education and advocacy about palliative medicine and ethical issues relating to serious illness and the end of life. Based on questions she has received, at presentations she has given, and from patients and their families, she recently wrote a book titled Intensive Caring, a practical handbook for Catholics about serious illness and end-of-life care, and that's with Ave Maria Press. And Dr. King lives with her family and enjoys life in beautiful Utah. And so, Dr. King, welcome. Welcome to this evening.
Thank you, Dr. Vaughn. It's a blessing to be here and be with all of you, although virtually. It's just such a great opportunity to talk tonight and have this conversation, and I appreciate you joining us.
Well, and I just want to echo Dr. King's sentiments. Thank you to all of you for being here because this is such an important conversation. Now, before we start our conversation, however, I have some instructions. I'd like to go over the format for this evening. Dr. King and I will have a conversation for about 45 minutes, and then we'll open it up for questions from registered participants. And so that's you all. Everyone who's involved here can ask a question. And the questions can be posted at any point during the interview using the Q&A feature at the bottom of your screen. I will be moderating the questions as they come in, and I will pose them to Dr. King during the Q&A portion of the event. And do note, you can make your questions anonymous if you choose by editing your name, should you wish. Okay, so you do have that option. You can also, I'm not going to announce who is asking questions anyhow, but you just do have that option if you like. We're also using closed captioning, which you can activate at the bottom of your screen. And what I've also done, I hope I have done this successfully, in the chat, I have posted a link to the transcript. And so this is a way of viewing the closed captioning, um, not as I run along the bottom of your screen, but in a sort of separate a part of your screen that you can see the closed captioning. So you have a two options there for closed captioning. All right. I hope that makes sense. You can use the Q&A button if you have questions for me about any of this as well, any of the formatting, structure questions or anything like that. And I'll try to keep an eye on that for that reason too. Okay. Well, let's get into our conversation. So, I thought before we start talking about some of the issues having to do with end of life, Dr. King, I was wondering if you wouldn't mind explaining for us what is palliative care? What does that mean? And maybe a little bit about your own story. How did you find yourself working within palliative care medicine?
That's a great question because I didn't even know about it growing up, I'll tell you. And when I said I was going to go into it to my family, they asked me what it was. I mean, it's not something that is super common as a medical specialty, but the word palliative comes from the word pallium, which means to cloak. And we think about cloaking someone with support when they're going through a lot in their health. And so I'm kind of like the specialist in medicine as a palliative care doctor who cares for people with serious illness. And so it's a medical specialty, just like oncology or cardiology. You do extra training in it. And it's a 1 year fellowship. They have also pediatric palliative care, but it's for patients who are going through a lot in their health that impacts their general life. It maybe the disease impacts their symptoms. They have a lot of symptoms or side effects from their treatments or just stresses from the illness. And so when we're thinking about serious illness and the kind of diseases that a palliative care doctor would care for, we're thinking about things like any sort of organ failure, kidney failure, lung failure, heart disease, liver disease. We're thinking about things like strokes, progressive neurological conditions like Parkinson's disease, multiple sclerosis, ALS. We're thinking about things like cancer or people who've had just catastrophic traumas and find themselves in very difficult situations. So all kinds of diseases like that would be appropriate for palliative care. And we really work, I say that because palliative care is a team sport. I say you work with nurses and doctors and social workers and chaplains because we know that a serious illness like this affects all parts of you. It's not just a medical problem. It affects your social life. It affects your financial situation. It affects your emotional health and it affects you spiritually. And so we know that really working to address all aspects of how this disease affects you is the best way to care for you so that you live the best life possible for as long as possible. And really that's what palliative care is about. It's about you living your best life. It's not about death and dying. It's about helping people with difficult illnesses. I mean, yeah, that does extend to end of life, but it's not all like what I'm focused on when I'm meeting someone. So palliative care is available at the time of someone's healthcare diagnosis. It can be any point along the diagnosis, really, when it could be helpful to have this kind of support. It could be when you have a relapse of disease or you were doing pretty well, but then your caregiver who has been your main support, they got sick and now things are a lot more difficult. Maybe palliative care could be helpful for helping you with your family and like telling your kids or really working with you as a whole. It's caring for the patient, we say, and everybody who loves the patient. So we meet a lot of times with family members of patients and palliative care is for the whole spectrum of life too. We have palliative care for pediatrics, palliative care for adolescents, for adults. It's not just for elderly patients who are nearing end of life. There's even something called perinatal palliative care for people who might find themselves like parents who are pregnant and are going to have a baby that they learn has a likely low chance of living very long, then palliative care can meet with this family to help this baby live the best life they can for as long as they can. So it's a really beautiful concept that is just there to walk with people with their health difficulties and make life the best it can be. So I hope that kind of helps give you background about what palliative care is.
Very much so. And when you were talking about walking with patients, it reminded me of Pope Francis, who of course just recently passed away, and an aged gentleman who suffered from a debilitating disease near the close to the end of his life. I mean, here's a man who talked about accompaniment and accompanying the whole person. So we haven't gotten into the Catholic side of things yet, but I can definitely see already resonances with that. Well, while we're talking about terminology, so we have palliative care. How does that differ from hospice care?
And that's another great question. And it's something that often is very confused. Like people get confused about it, or they might use palliative care and hospice interchangeably, but they're quite distinct things. So how you want to think about it is palliative care is this big field of medicine to support people with serious illness, and hospice is a subtype. So it's under the umbrella of palliative care, but it's for particular patients who are very much appropriate for hospice at that time. And so it's a Medicare benefit. It's a program that we have in the United States. That's kind of how we think about it. But it's for people who have what we call a terminal diagnosis or prognosis of likely 6 months or less. But we don't ever know with a crystal ball. Doctors are pretty bad at this at times. And so it's meeting certain criteria of a disease. So you have your serious illness, but you have to be more in advanced stages. But in addition to that, and it's really actually more importantly, you have the philosophy of hospice. And so for most patients I'm caring for with palliative care, for most patients who are dealing with a serious illness, they're fighting their illness the best they can. They may know it's not curable, but they're doing what they can to keep living the best life. And that's what I'm doing to support them. I'm helping with pain management or symptom support otherwise, or emotional support, and just kind of walking with them, like you mentioned, that accompaniment. But it might come to a point where the patient's getting refractory to their treatments, or they're going back and forth to the hospital all the time, and they really find that they're not getting better, that it's really burdensome kind of walking with this disease and kind of the way they have been, and that disease-directed approach where we're trying to do everything we can to ward it off or slow its growth or slow its progression. And so you might at some point decide, well, I'd like to make a pivot. I'd like to focus more on not going back and forth to the hospital all the time. I'd like to focus on spending more time with my family rather than trying more chemotherapy or continuing dialysis or getting more blood transfusions or whatever it is. I'd like to focus on being more comfortable and just feeling good and eating what I want and doing what I want. And that's kind of at the time, I believe that hospice is going to start coming up in conversations. And that's when it could make sense to switch from the traditional palliative care, which means you have all your other doctors and all your other medical support you have, like going back and forth to the hospital, to where you say, you know, I'd rather be around my family, or I'd rather just be in my home. I'd rather not go and continue with all these intensive medications and treatments. I'd rather focus on comfort. And that's more of that hospice philosophy. And so all along the course of a patient's illness, when someone might have palliative care, they don't lose any of their other doctors. They still have their cardiologist or their oncologist. I just say I'm your support doctor on the side. You know, I'm here to walk with you. But at the time of that transition to hospice, typically the palliative care team, the hospice team specifically, they would kind of take over and they would be supporting the patient and their family through the end of that person's life to the natural death. And it's not like you're just throwing in the towel. It's still can be a really beautiful time for people. And sometimes people live longer actually having hospice support. It's actually a more intensive support structure. Like you have a lot of people that can come to the home, and hospice often has bath aides, like helping with bathing, helping with medications, social workers and chaplains that can all come to the home in addition to the nursing medical care. And it's really nice for people who have been just very stressed and dealing with their illness progressing. And so at the appropriate time, that transition to hospice can happen, and it can be very smooth. But as you can see, it's a very specific time in the patient's trajectory of illness, and it's different than the whole framework of palliative care.
Thank you. That was really helpful. As a follow-up question, you mentioned disease-focused care, I think is the way that you put it. Is palliative medicine, would you consider that, is that disease-focused?
I think so. And I really kind of get a little annoyed sometimes when people will say in the hospital, oh, this patient's just going palliative, or, the patient's seeing palliative care now. So that's really scary and bad. And I'm like, no, like, actually, what put palliative care on the map is we had this study done of patients with lung cancer, advanced lung cancer. So we already knew it was an incurable disease. And we had the patients that had their normal cancer doctors and radiation cancer doctors and chemo and all that. And then we had the people that were in a second group that had all that normal cancer care and a palliative care support team. The people in that second group, they lived longer, like 3 months longer than the first group, and they spent less time in the hospital. And usually, less time in the hospital equates to a higher quality of life that a patient would report, meaning they're just doing better, enjoying life more. And so it was showing us that palliative care doesn't take anything away. It's still, fighting that good fight. And like you mentioned, disease-directed care. And that's really what my job is as a palliative specialist, is to say, okay, I want to get to know you as a patient. I want to learn your values. I want to learn your preferences around your healthcare. And then I want to help you carry those forward and make sure they're a reality in your healthcare. And if you're saying I'm all gung ho with every chemotherapy they're going to offer me, and I'm going to fight and go to the hospital and be very aggressive, then that's what I want for you too. I'm with you. I'm in your corner. And if there does come to a time when we decide to kind of scale back or think more about that comfort approach or hospice, that's a totally different conversation. But that's when your goals have changed. But palliative care kind of can do, and support patients in all the spectrum of illness.
So it sounds like palliative care is, I mean, you're focused on the entire person. You're focused on their care. But at the same time, you are still very much concerned about that disease. You're very much concerned about their physical health, but you always have that larger context of their whole personal, all their different dimensions that they have as a human being in view. Which I suppose is true for many different fields in
Right.
medicine. Yeah.
And I think it's just when the serious illness happens, it's kind of, it brings everything to the forefront and kind of a magnified view sometimes. But we know that if like someone has a lot of spiritual distress or they have untreated depression or anxiety, I'm never going to get their pain well managed. Like I have to really work at all the aspects of suffering that they're going through to really help them toward the optimal healing and best being able to fight whatever they're trying to fight and work through. So it's challenging at times, obviously, but
Yeah.
it's a real gift to have the time to delve into that. And I when I get to meet patients, I often ask, like, where would you be if you weren't talking to me right now? Like if you were healthy, and I kind of learn like what's important to them, who's important to them. When I was at my previous hospital, I made this like a little sheet that I gave to the family members of patients, because often I was meeting people in the hospital in a crisis, like they were on the ventilator in the ICU, they couldn't talk to me, or I'm not seeing them in their normal state of living. I'm seeing them in a very much compromised state. And so I would give this homework assignment to the family and say, will you please bring in a photo of how the patient would like to be seen by their medical team? And it was just fascinating to see like the robust dynamic life that these people led. And it would really help inform the doctors and nurses that 2 weeks ago, this patient was water skiing, or, this patient was enjoying time in their yard or with their grandkids. And that's really what we're trying to get back to. Just reminding everybody that bigger picture of a patient, not just in a blue hospital gown connected to a machine, but this dynamic, robust individual that we're trying to really care for. So I like to think that palliative care brings kind of that humanity piece back sometimes that can get not lost in medicine, but kind of not put to the forefront. And that's really where we try to elevate that and remind everyone of like who this patient is and how we can carry who they are through their healthcare journey.
I can certainly see the importance of the team with such a holistic approach to the patient. And as you mentioned before, reaching out to the ministers. I was going to say campus. Right, I was going to
Yeah.
say campus ministry because I just work within a college setting here. But we have important there's the chaplaincy, the chaplains that are available, but also other counseling services and psychiatry and all that would go in as well. Um, so so thank you. You've helped us, I think, to get an idea of what palliative um, care is, what a little bit of what it looks like. Maybe we could get into some of the issues. So, as a palliative medicine physician, what are some of the issues that you have encountered in palliative medicine, palliative care, that you think we should be aware of? And maybe help explain why we're having this conversation right now and why this is important for us to have this conversation, whether you are suffering from a debilitating illness or not, or in need of palliative or hospice, whatever. Can you say a little bit about some of those issues that one might encounter?
And I think it's hard to like, especially when we're in good health, to be thinking about these kind of things. It's not really fun to think about. It's not conversations we want to have with our loved ones. But they are so important. I mean, we as a culture kind of ignore our mortality often and don't think about how we are so fragile in our health and life can change in an instant. But for people who have serious illness, they're often reminded of their mortality more often. And the trajectory of serious illness can vary between different disease states. So, someone with dementia may have more of a progressive, kind of gradual decline over years. Someone with cancer, depending on the cancer, could see a huge change in their functioning abilities within months, even weeks sometimes. And then you see people who have massive traumas or strokes, and that's sort of an instantaneous change in what their previous level of functioning was. And so these conversations, there's never a better time, I think, than the present, or to think about some of these issues. But I deal with things in the hospital primarily. That's my position. But in palliative care and with serious illness, we're thinking through a patient's trajectory and thinking about things in the terms of hoping for the best, but preparing for the worst. And so we talk about all sorts of things like life support machines. Would something like a ventilator be something you would be interested in going on if you had not been able to breathe anymore? Or if you have chronic kidney disease, would you be interested in dialysis if your kidneys worsened to a point where they couldn't function on their own? Or how would you feel about a feeding tube if it got to a point where you're not able to safely swallow for yourself after a stroke? Or things like cardiac resuscitation. If you passed away naturally, would you want chest compressions and shocks and to be kind of resuscitated in that aggressive way? Even thinking through like as patients I care for might be declining in their health, maybe they need a higher level of care. So we're talking about maybe placement in a care facility, not living independently any longer, which is very hard, not being able to drive or care for themselves in the same way. I think that some people with a limited life expectancy kind of process through their death and what that could look like. And we talk about what's a good death for you, or what would you like your dying process to be like? Would you like to die at home? Some people say, yeah, being home surrounded by family, being comfortable is really important. Some people are okay in a hospital or being on machines. Um, some people might even be bringing up the idea of hastening their end of life process if they learn they had a difficult, a serious diagnosis. So these are all kinds of issues that can come up in palliative care, things we're talking about, thinking through. The goal through having these conversations is not to make everyone all depressed. It's really to help give peace of mind to patients and their families, and to be clear to the medical staff, because there's not like a black and white cutout of like what everyone does that's similar. You have two patients and they both have the same disease, but they might really choose different options. And it's all based on, your values and kind of how you feel and what's a threshold that you're comfortable with? Because today in medicine, we have so much medical technology, we have so many options that sometimes it can seem limitless. Like there's always going to be another chemo treatment that you can have for your cancer or something. And that's how it might feel, but there might come to a point where that's too much for me. Um, and so I think that any point that you can have these conversations before you're in the midst of a crisis, because that's where I work and I'm kind of navigating with families. Often in my situations, the patient can't speak for themselves. So we're doing our best guess at what the patient would want. Some people were fortunate that they have some sort of advanced directive that might detail some of their beliefs, or they've had conversations with family members that it's very clear, like my mom would never want this, or, but I think that as much as we can do to be clear to those we love about what would be our thresholds or what we'd be okay with, or speaking to your doctors about it, if a crisis does come up, there's just so much more peace of mind in that situation. So, yeah, I'll stop there, but a lot
Yeah, no,
to talk about a lot.
the so a lot, there are practical things that can be done at any stage, isn't it? And that we can talk to our family, talk to our healthcare professionals about those values and about those limits. That's kind of what I'm hearing.
Yeah, I think it's really important. And I mean, I was at a dinner party with people in their 30s and I gave all of them advanced directives to fill out, and they, I just they were kind of grateful actually because yeah, I mean, you never know in different states and different laws, and it's never too early to kind of think through this for yourself. And it's sometimes surprising to think through and be like, oh, actually, I didn't realize that's how I believed or what I felt about this. And maybe it's different than what my mom would say. Or, it's just really important to think about it. And it never seems like there's a good time, but there's always a good time, and it's the present, I believe. So
Sure. Sure. That must have been quite the conversation at that dinner. Um, that's great. The now you mentioned at the beginning of your response, you mentioned the culture and our attitude towards mortality. And so this kind of gets into my next question here, and that has to do with, well, this talk, this interview is sponsored by a Catholic Studies program at a Catholic college. And it's in the title, we're looking at end-of-life care from a Catholic perspective. And so I'm just kind of curious then, especially as a physician, what does the Catholic Church bring to the table when it comes to end-of-life care? And I guess one of the questions that I also have that's connected with this is, to what extent do you think that the Catholic Church has anything to offer people who are not Catholic?
yeah, that's a great question. Both of those are good questions. I think, like I work in a secular healthcare system, and most of my patients are not Catholic. And yet I am immensely informed as personally inside, in my practice as a physician by my Catholic faith. But that doesn't mean I'm uh, evangelizing to each patient or praying the rosary with them or anything like that. But as I hope I can share the principles of what the Catholic Church teaches about the end of life and the dignity of the person and the sanctity of life, and um, how each person matters regardless of their functioning abilities in our world. There's some beautiful concepts that I think make me a better doctor and truly apply to any patient that I'm caring for, and really would be the care that I would hope for anyone. It's really about um, really that dignifying care for that individual, that as a person, and especially people that I'm caring for are in very vulnerable states. So on a personal note, I'm very grateful to the Catholic Church, but I think the Catholic Church has given so much to medicine in general and about caring for patients, and about really just the right world, like the way to think about caring for people who are dealing with difficulties. So Um, Specifically, the Catholic Church gives great direction around end-of-life issues, and it really puts like a roadmap of how to kind of process through these decisions around healthcare options. And so Pope Francis has spoken a lot about the culture, which he kind of criticizes the throwaway culture. You may have heard of that concept.
Yep.
And what he means by that is the victims in our throwaway culture are the weakest human beings. And for me, that totally applies to patients who are dealing with serious illness. But um, the culture kind of discards these people, these weak people, when the system aims for efficiency at all costs. So that's kind of what he's criticizing. And whereas the Catholic Church perspective is really looking at a culture of love and of life. And so I'm going to kind of contrast this throwaway culture with kind of the Catholic worldview. And so this throwaway culture that Pope Francis has written about really looks at someone's quality of life in kind of a utilitarian perspective, which means kind of like what they can do, how they function impacts their value, their worth. So people that have certain abilities would be worth living, or people that don't have discomfort, they would have like life worth living. But if someone has a lot of discomfort, suffering in their life, like that would be a life not worth living in that kind of worldview. Human life in and of itself is not considered a value. Whereas the Catholic Church would say, whatever someone's physical or psychological condition, human persons always retain their inherent original dignity as being created in the image of God. God's call is to appreciate that human good is the primary common good of society. Human life is the highest good. And so society is called to acknowledge this. Life is a sacred and inviolable gift, and every person created by God has a transcendent vocation to a unique relationship with the one who gives life. So these are some quotes from Pope Francis. And he also criticizes that there's a very pervasive sense in our culture of radical individualism, or you might think of like autonomy, where our own good is higher than, and our own decision making, our own ability to make decisions and control things is really of a high good. And another person, especially one with some limitations, would be viewed as a threat to our freedom or considered a burden. And so in the culture, in this sort of sense, there's a lot of isolation, less dependence on other people. And that's really inherently false, Pope Francis says, because at our deepest level, we depend on God and others. So when you think about things as like autonomy being the highest good, then of course that would extend to being able to control everything about your life, including how you die. And so that's where these movements around hastening death, these practices like physician-assisted suicide and euthanasia come up. The Catholic Church, their perspective would be that we really aren't here to abandon people. The Catholic Church views assisted suicide and euthanasia as the ultimate abandonment. We're not here to say that at some point your suffering gets to the point where we eliminate the sufferer. Like that would never be okay because of your inherent dignity as a person. Rather, we would say that we're here to accompany you. We're here to say that I'm with you. Your illness doesn't define you. You are so much more than that. And I'm not here to abandon you. I'm here to stay with you. I'm here to treat your suffering. I don't want you to suffer, but never at the extent of killing you because of your intrinsic worth. The culture, going back to one more point, in this sort of throwaway culture, this sense, if you have this sort of mentality of utilitarianism and thinking that someone's life is all about their control over things, then there's this sense that can come up of this misguided compassion, where if you're suffering a lot, then their ending your life might be justified in the name of compassion, holding that it would be better to die than to suffer, and it would be compassionate to help a patient die by means of hastening their end of life, euthanasia or assisted suicide in that kind of process. And that's very deeply contrary to the kind of already what I've talked about with the Catholic Church. And John Paul II And he taught about solidarity, and he taught about how these practices are really emphasizing a culture of death, not that of life, and that they're really erroneous. These hastening practices are erroneous responses to caring for terminal patients and the challenges therein. The Catholic Church would say, rather than viewing someone with this kind of compassion, they call it misguided compassion, we would really look at them with what they call a contemplative gaze that beholds that one's existence and that of others is a unique and unrepeatable wonder, which it's sometimes hard to think about someone who's really debilitated with wonder, but to think about them as a gift, like there's a gift that God created, this person that we receive and we welcome them as a gift. This is a gaze that we look at someone, we don't take possession of the reality of life, and like life isn't ours to control, but welcomes life as it is, with its difficulties, with its sufferings. And guided by faith, we find in illness, even in illness, the readiness to abandon oneself to the Lord, to surrender to God's plan. And so it's challenging. These are hard concepts to grasp. And you can see how the Catholic mindset is very countercultural. But it's this underlying sort of thinking that is really that views the patient as this, someone very worthwhile, someone to cherish, not someone to discard. And I think that really, that sense of looking at a patient with eyes full of love, and especially in today's world, like that kind of sense that I try to bring to the bedside. I It doesn't matter your faith, doesn't matter your background. It's truly something that I can offer to all patients, and I believe is really what medicine is meant to be.
And so thank you so much for that. So all of this applies, that's why I just want to be clear, to even to the patient who, on an emotional and spiritual level, may feel distant from God. They may feel distant from any kind of meaning or purpose. They might be smothered in their suffering. Um, this the church still wants to say that there's a meaning here in this person's life.
Yeah, I think that for people that are dealing with that kind of suffering you're talking about, we call it existential, that deep suffering, regardless of religion, regardless of faith, just illness can sometimes very much affect the core of who we are. And it can affect how we view our own identity and how we view our value, like our personal value and meaning in this world. And sometimes patients will feel like this disease has robbed them of all that mattered to them and all that who they really were. And it's in those situations sometimes that people ask for hastening of death. They ask for assisted suicide. I mean, that's really what the studies show is what the biggest driver for people. These kind of issues are what drives them to ask for this and seek it out, rather than people with uncontrolled physical pain. It's these deeper existential issues. And yes, I'll tell you, Dr. Vaughn, this is some of the most intimidating stuff for me as a palliative care doctor, because we don't get great training in this. I mean, this is hard stuff, and I'm not a spiritual counselor by any means, but I'm here to say to this patient, you still matter. Thank you so much for sharing this with me. I'd like to walk with you. If you'd give me a chance, I would like to keep caring for you. And I believe, usually I delve into the patient's values. I delve into what has given them meaning in their life, who matters to them, what matters to them, um, and how can I help them see that life still has as meaning, that the disease has not defined and taken away all their joys. And if they would let me walk with them and give me a chance to help them, I think that we might be able to kind of keep life going. Um, I'm not here to have them suffer. That's definitely not the point. I'm here to reduce that suffering. Honestly, when I meet patients, I sometimes will ask them, because we use a lot of 10 scales, 1 to 10 scales in medicine, like put your pain on a 10 scale of 1 to 10, how bad it is. And I say, rate your life on a scale of 1 to 10 right now for me, like 10 being the best life ever and 1 being life in the pits. And how would I get you from, if they say, oh, doc, it's a 2, it's really bad. Then I'm just like, okay, well, why is it a 2? And what would make it get to a 3? And how can I help you get there? And we have to think outside the box sometimes. We have to be creative. And it takes time, and to dig into this with patients, but I think it's some of the most worthwhile work I can try to do as a palliative care doctor is to help these people know that they still have value.
You mentioned suffering, and so I want to bring up something that you often hear when it comes to the Catholic uh, perspective on end of life, that Catholics are prolonging suffering, and even more than that, there's a kind of glorification of suffering for Catholics. How would you this talk about finding meaning in suffering? I think some people hear that and they think, well, is the Catholic Church teaching that suffering is a good thing in itself, and isn't that a glorification of suffering? How would you respond to that?
I would say that the Catholic Church does not think suffering is good. The Catholic Church believes that it's good to treat suffering and it's good to treat pain and it's good to manage your symptoms and work to have your optimal health. Okay, the Catholic Church would teach that. The Catholic Church would say that suffering is not pointless. Suffering has meaning and value, and it unites us to the suffering of Christ. It's part of like the Christian walk as like carrying the cross. Suffering has meaning in and of itself. And I'm not a theologian, but I think that, and there's a lot on the theology of suffering. We could have a whole discussion on that. But as far as that, we think about it in medicine, I think that's true. Some people think also as a Catholic, you have to do everything possible to stay alive as long as possible, or you need to um, or you can't take pain medications, or they have these sort of thoughts about some of this, and that's wrong. So regarding pain, the Catholic Church teaches that it's good to treat pain, um, but not at the extent of sedation or hastening end of life. So there's a fine line sometimes. But as I like have a patient who's in a lot of pain, I start at the lowest dose that's effective and increase as I need to. My goal as I give pain medication is not to sedate someone. I want them to be as mentally alert so they can interact with their families and make their own healthcare decisions. I don't want to just knock them out by any sort of means. There's ways that we can safely use medications in a way that really helps people have a better functioning. And so in palliative care, we learn how the safe use of medications like opioids. I think many people are kind of afraid of those medicines, and it's understandable. They're misused in some situations. But in palliative care, we have a whole different kind of philosophy of how we manage them in serious illness. And so we really work with patients to educate and to have safety structures in place, that these are good and standard of care, really, medicines for people. And when we're thinking about kind of looking at healthcare decision making and sometimes thinking that as Catholics, oh, we are pro-life, so we need to do everything to live as long as possible no matter what. That's really not true. So Catholics are not vitalists, which is a concept that means life at all costs. And there's a balance between living the best we can, but not clinging to life unrealistically, but also dying well the best we can and not ignoring the dignity of life, especially when we can't cure something. And so the Catholic Church gives us some guidelines to kind of work through that. It's hard because it's, again, not black and white. You may have heard of the terms ordinary or extraordinary care, kind of when thinking through medical decisions. Ordinary being basic, extraordinary being kind of extra or supplemental. But we don't really think of that as much anymore. We really want to put terms, they're kind of big terms, but the way that the Catholic Church suggests is thinking about things in terms of their benefit or burden in the eyes of the patient. And we use the terms proportionate or disproportionate. And so when you're thinking about any medical decision, when you're thinking about, let's just fill in the blank, it can be dialysis or chemotherapy or being on a ventilator machine or going back to the hospital or whatever it is, a big surgery. You put it on a scale and you say, okay, in my perspective, do the benefits of this surgery or intervention, do they outweigh the burdens? If so, that's proportionate. If the burdens outweigh the benefit, in my perspective, then that's disproportionate. And we are not morally obligated to do anything that is disproportionate to our care. And it's tricky because over time, the same intervention might have one point been proportionate, and then another time it's disproportionate. It can change. And two patients looking at the same treatment could be disproportionate for one and proportionate for another. So I'll just give the example of dialysis. We have two patients, let's say, both have kidney failure, and one is a 40-year-old mother of two who's had this chronic kidney disease because of a genetic problem. And she's kind of known, she's been followed with a kidney doctor for a long time. And she gets to a point when the doctor's like, I think we need to try dialysis. On the other hand, we have a patient who's, let's say, 80, so double her age, and he has dementia, lives in a care facility, he has some issues with hearing impairment, he has a lot of limitations. And he has heart failure, and the heart failure has caused him to go into kidney failure. And now the doctors are saying that he needs dialysis. So if you're thinking about it, each patient, if they're looking at whether dialysis is proportionate to them, may have a different answer or might be kind of thinking about it differently. I'm not going to say what's right or wrong. They both might choose it, they both might not. But it's different and it's unique to each individual person. And so that's a lot of my job, is helping people navigate these muddy waters and kind of thinking in my values and in my perspective, in my eyes as a patient, what is proportionate for me and what makes sense. And that's really working with the Catholic framework of making the right healthcare decisions in that time. And if you're ever making this decision for someone else, because sometimes you have a loved one who can't make this decision, what I would say is thinking about it like, what good can this do for this person I love? What harm can this do to him or her? Because if you refuse something that is really disproportionate, you're not committing suicide for them. You're not doing something that is really hastening their life. It's not really about that. It's about like allowing their health more naturally to evolve, because this would be something, like I mentioned, with medical technology, there's so many options that there's some point, sometimes we draw a line that it's just too burdensome for me, if that makes sense.
Yeah, and so just the two distinctions to walk away with, proportionate versus disproportionate, and ordinary versus extraordinary care. These are two, I know within Catholic moral theology, these are important principles that are being applied here. Wow, I have so many more questions to ask you, Dr. King, but we have gone over 45 minutes. And I really think there are probably a lot of people out there who've got some very excellent questions. I can see them already, that we've got a bit of a queue here lining up. So we're going to turn to the Q&A portion of this evening's interview. And so, as I mentioned before, I'll be monitoring the Q&A, the questions as they come in through the Q&A function at the bottom of your screen. Keep sending them in. So we'll give it like about 20 minutes for the Q&A. So get them in fast. And so I'm just going to start off with the first one here that I see in front of me. Okay, so here's this question. To what extent does palliative care entail offering direction and guidance based on prognostic reality, especially when patients request or even demand care and interventions that might be considered medically futile, versus simply supporting what patients want?
Yes, so that's a great question. And I think I've been on ethics committees and had physicians I've worked with that truly really feel like we're here to kind of be that cheerleader, be that support for patients. And this is not just my specialty. I remember a particular case of a cardiologist who had a patient requesting a cardiac procedure, and he felt in his mind that this patient should not get this procedure. He felt that they were too debilitated and elderly, like they wouldn't do well with it. But because the patient wanted it, because autonomy rules in our culture, in our world, he just was like, yeah, I did it. I did the surgery for her. And she did not do well. And I think, there was some ethical issues around post-operative management. And I said, well, why did you do that? We have to exercise our own conscience and our own, I think the culture sort of has naysayed this idea of paternalism. In the past, the doctor said goes, and now it's swayed this other way where what the patient says goes. And how I kind of view things is I'm the expert by my medical training, and the patient is the expert by their experience. I haven't been in their body. And so we need to put our two expertises together to come to a conclusion. And I think that as physicians and myself included, like we have to have courage to make recommendations. And I'll ask patients, and I try to ask their permission, to say, do you mind if I tell you what I think? Do you mind if I give you really the honest information about your prognosis? Do you mind if we talk about your prognosis? And it's funny, some patients will say, I don't want to know anything about my prognosis. But my thought is people going through serious illness, they often don't know really they're dealing with. So many times patients don't know that they have an incurable illness, or they may have a very limited life expectancy, but it's all over their medical chart. It's all over their cancer doctor's notes, but that the patient doesn't seem to get it. Now, did the patient not hear it, or did the patient choose not to hear it? I don't know the answer to that. There's different degrees of acceptance with these things. And I'm not here to be all negative to the patient or take away their hope. But at the same time, if you knew that you had an incurable illness, or if you knew that you had a limited life expectancy, might you live differently? And would that knowledge give you more power to make your best medical decisions that you could? And so I really work to empower patients, because these patients are often very vulnerable. They're dealing with a lot up against them, and navigating the healthcare system itself is very daunting and overwhelming at times. And so I think it's really important as a palliative care doctor to lay out the realities of a patient's health. A lot of times I'll be creative. I'll show them videos online. This is what this kind of heart valve you have looks like in this situation that you're dealing with. Or I'll draw pictures, or, whatever I can do to help get it through, because maybe in the 15 minutes their specialist had with them, that they didn't get into it, into the gravity of it. And in a palliative care meeting, I can take the time to go through that, because I do think it's a big responsibility. So thank you for that question. So I could highlight that aspect of the work we do.
I know that Dr. King, you have a section here in your book on communication, and just how important communication is with the patient, and of course from the patient to the palliative care team as well, but just how communications can be really key here. Yeah, thank you. Okay, so the next question here: during your time in practice, have you seen a shift in what is considered medical treatment versus basic care, such as food and water? Furthermore, does there continue to be ongoing debate on what constitutes life-sustaining treatment in palliative medicine?
Yeah, I think there are shifts happening. I mean, I think with the rise of hastening death practices, which we didn't unfortunately have too much time to talk about yet in our conversation tonight, but we do see that in all specialties, and palliative care included, that I think that people view sort of that basic mentality we would normally think of trying to regain people to health, oh no, it could be an option. You could just decide to die. You don't want to go anymore. We could, especially where assisted suicide is legal. I mean, it's very odd. It creates this weird dynamic for patients, and this might come up in with their doctors. And being someone who doesn't support this practice, and I actually worked for a healthcare system. So I guess I can mention too that this all came to a head for me when I moved for my first job after training. 2 months after I moved there, assisted suicide became legal in that state. And so that I had to really face head on with what it meant to be a palliative care doctor in that setting. And I got to see over my 6 years in that state how it unrolled and how it impacted the patients and my colleagues as physicians. And it did change the culture, and it continues to change the culture today. And I think to answer your question, it does. I think the view around certain things that we used to think is like basic treatments is kind of changing. It is kind of in flux to some people. I don't believe that it should change, and I try not, it doesn't impact my practice, but um, I think that the whole like control over your life and having that ability to make calls around your what your end could look like in where it's legal, assisted suicide is legal. It does impact that physician-patient relationship, and it does impact, I think, how people view some of these standard, what we used to consider more standard treatments.
Just a really quick question, Dr. King. So we use language like physician-assisted suicide, euthanasia. There's also medical assistance in dying,
Yes.
MAID. Is there a difference between these terms, or are they interchangeable?
Yeah, they are. They're different. So physician-assisted suicide is different from euthanasia. I mean, you might kind of hear them used interchangeably again, but they're different practices. So physician-assisted suicide is a practice where a physician would be um, sort of a little more passively involved than euthanasia. Okay, so physician-assisted suicide would be where a patient with a terminal illness, typically is what the law says, will seek this out and have go through a process, and then a physician will write a prescription for a cocktail of medications to the patient to take with the intent of ending their life. So that is legal in 10 states and in Washington, D.C. in the United States currently. It's up for legislation in more states this year. Euthanasia is different. It comes from the Greek euthanatos, or good death, and it's a practice more where the physician is actively engaged in the killing of the patient, like a lethal injection. Euthanasia is not legal anywhere in the United States. It's legal in several countries, including Canada. And so a lot of places where euthanasia is legal, they have both. And you might have heard the term medical aid in dying. That's referring to physician-assisted suicide. So I think a lot of proponents of this act don't like using the word suicide. That's not that palatable of a term. And so they'll use different terms and medical aid in dying, or they use the acronym MAID, M-A-I-D, and it just kind of makes it less kind of that human aspect. It's more of a medical process, a medical procedure that will take place to people can seek that out. So I hope that kind of distinguishes the two.
Oh, thank you very much. So some very real distinctions, but also some rhetorical distinctions as well. All right, well, get to our next question here. With physician-assisted suicide, a terminally patient is given medication that they take when they are ready to end their discomfort. Uh, I have personally seen, this person is saying, I have personally seen a family member in palliative care that had to be sedated and put on extremely heavy pain medications to provide them comfort measures. The amount of medication would make a healthy person sick. How is sedation and heavy medication through palliative care a better choice than allowing a patient the choice to hasten their death before they are suffering?
Yeah, this is like very hard stuff that we're dealing with. And I appreciate the thoughtfulness of this question. And I'm sorry, you know, because it is true. And we see loved ones suffer. And it's very hard to see another person suffer, someone that we love. And I very much acknowledge that. And so the key distinction, I think, as when we're dealing with caring for a patient who is having distress and suffering is something, the ethical principle comes up, the principle of double effect. And what is our intent in caring for this patient, and our intent of the medication? So is the treatment I'm doing meant to terminate the patient? Is it meant to relieve the suffering? Um, at times, there are points where it's a very fine line between relieving of the suffering, and it could help. It could impact the patient's respiratory drive or their ability to interact with family, as you may have seen in your loved one. But the goal is never to kill them. That's kind of the main distinction, the difference. I think that, and again, this is very, very tough. But I think the Catholic Church would teach that the process of someone's dying is is still there's still opportunities there for this patient to be loved by others, for this patient to exhibit love, for this patient to be cared for, and that's not something that we rob. Our life is not one that we're in control of impacting. Like, it's God's planned journey to direct. It's not our journey to direct, and so we're here to be with that patient. And with palliative care, we want this patient to be as comfortable as possible. But we're not here to take that life into our own hands. And that's kind of where the line is drawn. And yeah, we have the medical technology that's out there that patients could get, and that cocktail of medicines that someone gets in physician-assisted suicide is heavy doses of anesthetics, heavy doses of pain pills, pain medications. It's not a pleasant, cocktail by any means. Um, and and yet, at some extent, this patient is sort of robbed of this opportunity, to live their life. And who knows what, we don't believe that because you have an illness, all your life is gone, and you shouldn't be. Still, there's still opportunities for joy, for life. I know it's very hard to wrap your head around that, but I'll tell you what I've seen in patients who have have said, there's been studies done, like, if my life was changed to the point I was quadriplegic, would I still want to live? And they say that, it wouldn't be worth living, but then they will survey people who are quadriplegic, and they'll say, definitely, it's worth living. It's our mindset change. Sometimes we think it would not be okay with certain situations, but there's still life worth living. There's still joys worth having. And there's been stories about patients caring for patients, in like the persistent vegetative state, this patient who can't do anything for themselves. And yet the life and light and joy that they give to their care team who's caring for them. I mean, it's kind of hard to think about and hard to fathom, put your head around it, but there's still meaning and ability to generate positive experiences and joy despite significant suffering.
The next question, I think, is much more direct here. What's a death doula?
Oh, yeah. So you may have heard of a doula at the beginning of life, kind of accompanying a patient through their labor and delivery process and being their advocate. And it's similar to the end of life. I mean, a lot of people look at the bookends of life, the beginning and the end, kind of similarly in a lot of ways. I mean, when we are caring for people nearing the end of life, we're kind of like a midwife for the soul, is what people talk about. We're preparing this person for what's next. And if you think about it, and I don't do that again. I don't walk in and evangelize with my patients and talk about their afterlife, but I'm here to help them have the best end of life that they can, and supporting them and their family. And so we know that we'd have ideas around what we'd like our birth process to be like if we're, in labor. People talk about, oh, I'd like to have an epidural or I wouldn't, or, you kind of talk about what's ideal for me. I'd like this to happen. I don't want a C-section, that kind of thing. Well, it's similar at the end of life and how what we'd like our end of life ideally to look like. And so kind of putting this in place and having like a death doula would be someone that would kind of walk with a patient and their family, um, not being like the main medical person involved, but being like a supportive advocate for them and helping to make this transition as peaceful as possible.
Hey, we had another question here, but it looks like your response to the other question answered this question. So and so I just have I think a final question here for you, Dr. King. And then I think we can wrap up. What are your final thoughts? What would you like people to walk away with when it comes to end of life care from a Catholic perspective?
I would say that, well, I'll leave you with an image I often leave in my talks, and that's of a sunset. And you think about the light at the end of a day, and the sky is the most beautiful just when the light's about to be gone. And likewise, you think about a patient you're caring for nearing the end of life, and that light of life on this earth is nearly gone. And yet it can be the most beautiful time. It can be such a rich time for this patient, for their family. And that's really what Catholic palliative care is about. It's trying to ensure these opportunities for beauty. And I get to witness so much beauty um, as I walk with patients and their families. And I really want patients to know that life is still beautiful, even in the midst of a lot of challenges, even when there is darkness coming on, um, and the gift that they are. So those would be my takeaway.
Well, what a great takeaway. Thank you. A heartfelt thanks to our guest this evening, Dr. Natalie King, for a stimulating and meaningful discussion on such an important topic. I would also like to thank our closed captioner for this evening, Angie Sundell, for providing such an important service. And of course, a thanks to all of you who've joined us this evening, and all of you who've worked so hard to bring this interview to fruition. And just a shout out, if you enjoyed this and you're interested in other events at St. Scholastica, please visit css.edu/spotlight. That is css.edu/spotlight for a listing of lectures, concerts, all sorts of great stuff that's happening at the college, and most of which is open to the public. And so on behalf of the Bragman Program in Catholic Studies, I thank you all again, especially our speaker, Dr. Natalie King, and I wish you a very good evening and all the best. Goodbye for now. Well, thank you, Natalie.